Well, good afternoon, everyone. It's good to see many of you. Happy New Year, everybody. Welcome to the Center for Health Equity's Health Equity Jam session for January 2024. I'm Dr. Lisa Cooper, the director of the Center for Health Equity. And it's my pleasure to not only welcome you to today's jam session, but also to introduce you to our speaker. So we always enjoy music. First of all, I hope you enjoyed that music, even though maybe not for long. Maybe we'll be able to play a little bit more of it later. We usually feature music that is a favorite type or genre of our speaker. So I believe you were listening to some Afro beats just now. So we'll start with some informal introductions of our speaker and then a little bit more formal. So, or actually maybe we'll do it the other way around. We'll do the formal first and then the informal. How about that? All right. So formally, we know Dr. Bunmi Ogungbe. She's a nurse and a cardiovascular epidemiologist whose research is dedicated to advancing health equity. And also she does not only research, but engages in community-engaged interventions. She's an emerging leader in community-engaged research, seeking to advance cardiovascular health equity, both in the United States and globally. Her work in the United States involved implementing tailored cardiometabolic interventions, categorizing cardiac post-acute sequelae of COVID-19, and also methods to improve diversity in biomedical research. So we have a little one whose voice we can hear, which is delightful, but hopefully people will mute so you can hear the speaker. It's always nice to know that little people are interested in health equity so early in their lives. So anyway, Dr. Ogungbe's global cardiovascular work focuses on advancing team-based hypertension care and novel hypertension medication adherence approaches, among other factors. So we are going to get some fun facts about Dr. Ogungbe. So first of all, let's see. She and I share something in common from our early years, an experience that we both share that not so many people do in the United States, I don't think, with their children. So any guesses on what maybe one of her experiences that she had as a young person that I also had as a young person? Somebody's been like cheating, I think, or maybe not. Dr. Cruz, great, you got the answer. She went to boarding school, so somebody else was guessing a beauty pageant. Well, that's a good guess because our speaker is definitely beautiful. So, but she went to boarding school and for 6 years. I was actually in boarding school for only 2 years, but so that's something that we share in common. Let's see, there is a game that Dr. Ogungbe is particularly skilled in playing. And anybody want to guess what that is? I won't tell you whether it's a physical game or a board game. You have to figure that part out. Oh, somebody said soccer. What do you say about that, Bunmi? Football, Monopoly, all good guesses. Catan? I don't even know what that is. What is Catan? Well, we don't have any correct answers yet. Oh, it's a strategy board game. Well, you're the closest, Christina, because Bunmi used to be a chess champion in high school. So she is a strategist. You can say that. Another thing she did, she has done some work professionally before she came to do her graduate work. So any guesses about what kind of work she did prior to graduate school? Ah, I see. Dr. Cruz is admitting that she knew some things about my personal background. So that's how she was able to guess about Bunmi Ogungbe. Ah, so Katie Nelson says she was a midwife. Yes. Bing, bing, bing. She worked briefly as a midwife in Nigeria. And this is the sweetest fun fact, I think. One of the children she helped deliver was named after her. Isn't that sweet? Yeah, that's so nice. That's one of the blessings of, I think, working in that field, is sometimes you get children named after you, if you've been particularly kind, of course. Well, there's one more fun fact, which is another thing Dr. Ogungbe and I share in common. I didn't know we had so many things in common. But she's taking a class right now. And how many people want to guess what her class is in? It's not an academic subject. Although I guess people, some people might want to make it academic, but theology. I don't know. Yoga? Interpretive dance. Well, I would say that's the last answer is the closest to the truth. Dr. Ogungbe, just recently, do you want to tell us about the formal dance classes you're taking?
Yes, I started to take a formal dance class, and the first time I did just the general waltz and ballroom dancing and the different ones, and I think I'm going to go back and start honing in on one of those. But it was really fun. I enjoyed it.
That's awesome. That's awesome. It's nice to have outlets like that. As we all know, we are multifaceted people. So anyway, without further ado, I welcome and introduce you to Dr. Bunmi Ogungbe, who is going to share some of her work with us today in cardiovascular epidemiology.
Thank you.
Well, the one thing I didn't mention, I should mention that I've had the pleasure of co-teaching a course, a third-term course in the Bloomberg School of Public Health with Dr. Ogungbe for the last couple of years. She was a teaching assistant with me prior to joining the faculty, but now that she's joined the faculty, she and I will be co-teaching that course. So if you haven't signed up yet, third term begins in a couple of weeks, and we'll be teaching that class together. And now over to Bunmi.
Thank you so much, Dr. Cooper. And thank you, everyone, for being here. Thank you for your interest in this work that I'm going to talk about. And as Dr. Cooper introduced, I am a very new assistant professor at Johns Hopkins Schools of Nursing and Public Health. And today I thought it would be good to share how cardiometabolic health interventions have been tailored for our neighbors. And by that, I mean within the US or locally, as some people would like to say, and also around the world. And by that, I mean globally. One thing I do want to start by saying, which I think is an interesting quote given the title of this talk, is that we are more alike than we are different, which is something that Maya Angelou said when she was with us. And I think this point is very important because as much as we have boundaries between countries and we have different cultures and people may speak different language, a lot of things makes us more human. We do have a lot of thread that makes us a lot more similar to each other. And some of our lived experiences are similar as well. And sometimes it's helpful to focus on some of those things that makes us similar rather than place a lot of emphasis on the things that makes us different. I wanted to share a little bit about where I'm from and how I got here. And some of those things we've sort of talked about already as we shared some of my fun facts and some of the things that I've done before. So I am from Nigeria. I was born and lived the first 2+ decades of my life in Nigeria. And I did some community engaged work, even though I didn't know that's what I was doing at the time. We called them campaigns or health campaigns. And I would go with my colleagues then when we could. This was after college. I would go and we would go conduct blood pressure screening. And here, this image is not the brightest, but there is that the sphygmomanometer, for those of us who ever used that, the mercury blood pressure device. I was using that and measuring blood pressure at the time. And then after that, I did some volunteering. And even as I was with that group volunteering, I remember that I led the group to conduct some community-based screening. And there we are trying to collect some blood samples, a few drops of blood to measure random blood glucose. And after that, I came to the US. I started my MPH at Jackson State University in Mississippi, where I spent some years before I came to Baltimore and to Johns Hopkins. And it's been an interesting experience, and it's been and I've thoroughly enjoyed the opportunities and especially the mentorship and the home that I have found here. This is a brief outline of some of the things I will talk about today. A lot of this, as I prepared the slides, ended up being heavy on the disparities part and just the burden of cardiometabolic conditions, both in the US and globally, and some of the factors driving these disparities. Okay. Cardiometabolic conditions, as you know, there's a lot of them. They are perverse, but not just a lot of them. They also share very similar risk factors. A lot of people have one form of cardiometabolic condition or the other. And to sort of narrow down the scope, I will probably really focus on a few of this. But the major point here is that the risk for one cardiovascular or one cardiometabolic condition usually increases as the other increases. So when we think about, for instance, high blood pressure and how that in itself, or hypertension, is a risk factor for several cardiometabolic conditions. The major ones that we tend to focus on are cardiovascular diseases, diabetes, chronic kidney disease. And very recently, this term was introduced in an AHA presidential report, I would say, and led by Dr. Ndumile. And they came up with this term called the cardiovascular kidney metabolic health. And the rationale for this is pretty much what I just said, which is that a lot of these conditions are interrelated. The risk factors are interrelated. Some of the drivers in terms of the prevalence and the burden of these conditions are interrelated. But not just that, even pathophysiologically, there's a lot of interconnection between these conditions. And so it sort of made sense to define a term or sort of a syndrome that captures the interplay, the interrelatedness of cardiometabolic conditions. So hence cardiovascular kidney metabolic syndrome, or health, if you want to say, but syndrome in this case. And it's defined as a health disorder that is attributable to connections among obesity, diabetes, chronic kidney disease, and cardiovascular disease, of course, including heart failure, and stroke, coronary disease, and other kinds of cardiovascular disease. And the one good thing that came out of this advisory was sort of the stages where this happens. So usually there is that, for instance, stage 1 here, which is defined as excess or dysfunctional adiposity. And usually, from what we've known, and a lot of us on the call have patients who we see who have this spectrum of conditions. I thought it would be interesting to sort of introduce this syndrome or this term as the field sort of shift maybe towards using this term. Now, the interconnectedness of cardiometabolic condition also lends itself to different connections in terms of the approaches or the interventions to addressing them. So, for instance, weight loss or reducing body weight could have a lot of implications for not just one cardiometabolic condition. It may not just be, it could have implications for blood pressure, it could have implications for blood sugar, controlling those parameters. So there is, of course, this interconnectedness in terms of the risks, but also in terms of targeting interventions and at the point at which we can target those interventions. Okay, so I'll move briefly from that and really now talk about the burden and the disparities. And I would start by really looking at the global burden of cardiovascular conditions. One thing I want to say as I talk about these statistics, as I talk about these statistics is that we know that there are very critical gaps in terms of data from a lot of countries. So there is it is important to listen to the statistics with that lens, just keeping that in mind that there are some limitations. There are regions of the world where we don't have as much data as would be needed to present. And some of these are based on, a lot of these are based on estimates. So really looking at what's happening globally, some regions of the world have higher prevalence in terms of CVD, or even just cardiometabolic conditions in general. The prevalences are higher in regions. For instance, here there is a range between 5,881 per cases, so CVD cases per 100,000 persons in South Asia compared to over 11,000 in Central Asia. And using one high blood glucose as one of the risk factors, there's also that range as well, and what the corresponding disability adjusted life loss is. And now just trying to see what has happened over the years. There has been some changes. A lot of things have changed in terms of the burden of cardiovascular conditions. We've had some gains in terms of how the interventions that have been implemented, both at the local level, at the global level, at government levels, have helped. But unfortunately, there are several estimates that point out that some of those gains may be are probably being reversed in some countries and in some regions. And of course, what's important to also mention here is the double burden of disease, which is a term that is used to describe particularly in what we would call low and middle income countries, or some other underserved regions where there is still the high burden of communicable diseases or infectious diseases, as well as the growing burden of non-communicable diseases or chronic conditions. So it's just thought it to be good for us to visually see how this has changed since 1990 in terms of the global burden of cardiometabolic conditions. Now, really looking at one of the indicators of death or mortality, And this is also an area where there's been some gains. Now, this is data from, excuse me, okay. Now, this is data from, okay, there we go. I have a very sensitive mouse, I think. This is data from 1990 to 2022. And there is that we see the graph, there is a decline in CVD mortality globally, according to these estimates. The challenge is that there has been some conversations, or just some experts have indicated that this may seem a little bleak in the sense that there are some indications that this decline in mortality may be reversed, either reversed or may stagnate at some point. A very clear reason or rationale for that could be what has happened in the past 3 to 4 years with COVID-19, and how that, of course, has had an impact on this. So this is, I just want to say that this is a gray area in terms of how this data is being presented, and in terms of how we talk about this. But the main message is that we still need a lot of work. We do not want a reversal, of course. We continue to want this estimate. We continue to want less people to suffer and to die from these conditions, many of which are preventable. And this is also another graph showing the trends in terms of mortality, so not prevalence here. And we can sort of see how a lot of countries don't even have data to present. Now, really looking at one of the risk factors, hypertension as an example, this is from the very recent global cardiovascular hypertension report from the World Health Organization, the first time that they had released a report like this. And these bubbles sort of compare data between 1990 to 2019. And we definitely see the bubbles get bigger for a lot of regions. So several regions now experiencing a higher burden of cardiovascular, of hypertension in this case. And as we may know, more than a quarter of adults with hypertension live in low and middle income countries. Again, just saying that we definitely have our work cut out for us, and there's still a need for us to continue to implement interventions that we know could work in several regions around the world. Now coming back to our neighbors, to locally here in the US, what's really happening in terms of cardiometabolic risk factors, hypertension here as an example, but also cardiovascular condition itself. Based on a report that came out last year, 2023 report from the American Heart Association, we do know that about 1/3 of the US, excuse me, not 1/3, about half of the US population, almost half, 45% of the US population have hypertension, and this kills over 500,000 people yearly. Unfortunately, a lot of people remain undiagnosed. A lot of people have uncontrolled blood pressure, and a lot of people are not treated. And we know some of the reasons for this are some underlying disparities, both the ones that we know that is measurable and the ones that are not even, that we haven't even devised measurement tools for. I do want to immediately point out some of the other cardiometabolic risk factors as well, like diabetes, for instance. About 9.7 million adults in the US have undiagnosed diabetes. That is a very large number. And I thought it would be good to even speak about this in terms of like actual crude numbers and not just rates, just to be able to communicate the impact of this and how critical this is. And even a lot more people have pre-diabetes. This is all based on 2017 to 2020 data. And finally, in terms of the outcomes of this, or what this means, and this is, again, US data, about 224 people per 100,000 persons die from cardiovascular conditions in the US based on 2020 data. And what that means is that on average, someone dies of CVD every 34 seconds. And of stroke every 3 minutes and 17 seconds. So that tells us these are things that we probably know. I also want to be careful to not preach too much to the choir here, but also just I think it's important to visit those numbers every once in a while and really see and understand why it's important to do this work. Transition quickly to disparities and what's really happening in terms of different segments of the population being at a disadvantage than others. And by that, I mean being more at risk for various reasons, underserved for various reasons, not being able to access needed care for various reasons. And this graph is a common one from the CDC, and this is based on, I believe, up to 2017 data. So we do know that there are these disparities and that persons who are Black in the US are more likely to die from heart disease than other persons of other race or ethnicities. And in terms of cardiometabolic risk factors itself, we do see these disparities play out as well. That persons who are Black, persons who are Hispanic are more likely, for instance, to have obesity, to have diabetes than other people in the population. I do want to say that for this presentation, some of the slides, like the one we're looking at, are focused on disparities in terms of race, ethnicity, but there are other forms of disparities as well, from where people live, location, the rural versus urban that we sometimes may not want to acknowledge, age. There are other kinds of disparities that are that continues to be unraveled and that we continue to see. And this also sort of tells us the same story, that even though there may be some gains in terms of decrease in some of these rates, we do see that some groups see a lot more of this decrease than others. And for some groups, we're beginning to see an upward turn, especially post-COVID-19. A lot of the data we've been seeing has shown that there's been an increase in cardiovascular prevalence and deaths. All right. Thinking about the global data that we just looked at and the more US specific data that we just looked at, what are some of the key drivers? What are some of the things driving cardiometabolic disparities? I do want to say that generally we like to talk about this in terms of levels. So thinking about like the structural level factors to like factors those are factors that are more systemic, even political factors, economic factors, but then we also have factors at the community level and at the individual level, at the health system level. So it's definitely a multi-level, these factors are at different levels and they exert influence at each of these levels. To really bring in the global perspective, we also do know that there's a huge socioeconomic inequality between countries now, not even just but also within countries. But between countries, there is a gap. There is a gap in terms of whether people can afford to find food, whether people have good housing between countries. Now, within countries, and this is where I sort of hesitate to use the high income versus low income term. Sometimes we use it for convenience, but we know that within high income countries, there are these disparities as well. There is that big socioeconomic gap. There is that big divide. There are people in this country, in the US, for instance, who do not have access to care. There are people living in poverty. So this factors, I sort of want us to, if there is one thing that we should take away from this talk, and that's why the talk was named For Our Neighbors and around the world, is really just to point out that a lot of the inequities, a lot of the disparities that we see and that we talk about and that we report on are not only happening between countries, they are also within countries, even in countries that are quote unquote high-income countries. So these are some of the things that we've seen before, but I do like to share in terms of the context and in terms of some of the levels that I was beginning to mention. So from like economic stability and the gaps between people, neighborhood and environment, people not having good housing, structural discrimination and racism, which are very important determinants. There's also the social risks and things that really places people more at risk for cardiometabolic conditions, but also lived experiences, everyday discrimination that people face, health literacy, social needs, unmet social needs. These are examples of factors that drive the disparities in cardiometabolic conditions, some of the disparities that we just looked at. So moving really quickly to why we need tailored intervention, I do want to make a point here that the use of tailoring in this context is it's very different from precision. There are contexts where precision may be important or may be necessary, but in this case, tailoring really is to ensure that the user, people for whom these interventions have been developed for, their voices and their needs are incorporated into the development and implementation of these interventions. And why would we want to do that? We know people have different practices. There are things that are more important in terms of value to some people, and that could be different between people, between groups of people. We know there are differences in terms of access. There are people that may have more access, that definitely have more access than other people. We know that in terms of where people live, there are differences in terms of literacy, in terms of language and how people speak and the languages that they speak. These are some of the reasons why we definitely think it's important to have tailoring in the interventions that we implement. And this is supposed to really read benefits to tailoring in implementation of cardiometabolic conditions. It's important to think about how people or communities or cultures, the kinds of barriers that they may be experiencing, the kinds of social disadvantage, the kinds of disparities that they may be experiencing, and how a one-size-fits-all may not be the approach. There are varying degrees of these barriers. And all of that, being able to engage people, being able to include their voices in the interventions would absolutely improve acceptability, will improve relevance, buy-in from the community and from people that we are working with to implement these interventions. Of course, this would help enhance outcomes. Very importantly, I strongly believe, and a lot of people that I work with strongly believe, that tailoring interventions definitely advances health equity, and that's really key. Ensuring that we are engaging meaningfully with community, but not just engaging, but that their voices are being included and that the interventions are developed in response to that. Here are some of that again, repeating equity again. And some of these interventions that are tailored can be cost effective. Now, I'll put an asterisk on that because there is a there are different schools of thought, but it can be cost effective in some cases. And of course, it also helps sustain, it improves sustainability. I thought it would be good to talk about some of the approaches to actually tailoring programs. We may be familiar with several frameworks. We may be familiar with several approaches. I was trying to not repeat a lot of the things that we're familiar with. And I actually came across this very recent report from the WHO, and this is looking at this topic and this approach to tailoring health interventions and cardiometabolic interventions from a global perspective. And really, a lot of the major points, a lot of the domains in terms of approaches are quite similar. These are very similar to some of the frameworks that we already use in some of our work and in some of our research. But some of the things that this framework or this approach, some of the things that was pointed out or that was really championed or highlighted in this approach is to have a tailored approach, which is what we've talked about, that is people-centered, equity-focused, participatory, incorporating people's voices, of course, and that is evidence-informed. And these are approaches that really are trying to either that are behavioral or may not even be completely behavioral. And I say that to mean just by thinking about the ones that are more structural and that we could really influence policy-wise. I'll scroll through this really quickly, but some of the phases for really using the THP, the Tailoring Health Programs, as indicated in this report, was to, the first phase really is to do a situation analysis. Some of us may call this needs assessments, or even just doing the groundwork, which is reviewing what's already in the data, defining target groups and behaviors, engaging stakeholders, and defining what the issue is, what the problem is, and the agreed upon targets in terms of interventions. I will not go through all of this, but these are, I thought it would be good to just see how this is being done and how organizations like the World Health Organization, how they are encouraging partners and governments to consider tailored approaches and how this is being implemented in other places. And some of the considerations that I thought to add to that is, of course, ensuring that the designs are community-informed, culturally tailored, multi-level, multi-components, because we've learned that single approaches, especially towards cardiometabolic conditions, prevention of cardiometabolic conditions do not work as much. And then that we are leveraging adaptive technologies and newer technologies to tailor these interventions. This is really to show some of the key strategies to reduce cardiometabolic conditions. And there are a lot of components here, but some of the key highlights here is increasing social support, implementing systematic changes. And these systematic changes to really address the more systemic and the more structural determinants of health. It is very important to engage with groups and to make sure that there is that meaningful engagement. I do definitely want to highlight what is really, what these images, one of the things these images highlight, and which is to incorporate cultural, faith, and spiritual practices, which is important in the tailoring process. There are groups of people, there are people who we know for whom faith is important. And in designing interventions, it only makes sense that we would ensure that the things that are of value to people are being incorporated. And of course, technology, digital technology, digital health interventions can be very important. And as and can be impactful in terms of access and for a lot of other reasons. And it's important that we leverage these technologies. I really love this concept of reciprocal innovation, and I do want to share what this means and how this can be leveraged. This is really one of the key points I wanted to make in this presentation, which is that as we implement interventions here locally for our neighbors, it is also important that we think about how some of these interventions may have been, some of the interventions that have been implemented in other places, and how we can learn from that process. And what this means is interventions that have been implemented in certain settings can be tailored and can be adapted and extended to implement them in other settings. I'll quickly go to the definitions to make it easier for people who may be hearing about this concept for the first time. It really builds on the concept of reverse innovation, which is that new technologies, new methods, new ways, new care models, new ways of doing things, which have been developed or implemented in low and middle income countries, as an example, excuse the typo there, brought to high income countries to replicate. So for a while, reverse innovation was the term that was sort of used to describe this. But now, really looking at what reciprocal innovation gives us, which is more bidirectional, sort of harnessing bidirectional, co-constituted iterative exchange of ideas and resources and innovations to address shared health challenges across global settings. We can all learn from each other. Interventions that are being that have worked in high-income countries can be tailored and adapted to work in some low and middle income countries. I sort of hesitate to say that because sometimes there is a copy and paste that happens, and that's the whole point of talking about why there should be tailoring, there should be adaptations, and we shouldn't just replicate interventions without contextually adapting them. But I really do love this concept, and I think for some of us who are interested in global health work, who do some global health work, I think this is an important concept to think about or to even integrate into our work. And I wanted to provide a quick example of how this can be done. There are some projects or some studies that are listed here in the table. Some of them are being conducted at institutions like Hopkins, and one of the things that is being done with those interventions and with those projects is to have this concept of reciprocal innovation happening, which is that, for instance, one of the projects was originally conducted in Brazil, and has worked really well in Brazil. And now there is that bidirectionality happening, which is that some of the elements of that intervention is being replicated here in the US, of course, contextually adapted to the population, the people who are participating in the US. So here's an example that I thought I could provide of how this could work practically. But it's not just local global. It's not just high-income country, low-income country. It could also be rural urban. It could also be between a particular settings compared to another setting, a particular healthcare setting, I mean, compared to another healthcare setting. So there are different ways through which this could work. And this is I think this is an important concept to think about, especially for people who do implementation science research. Okay, here are some interventions. I think these are interventions that we may be familiar with, that we'll probably know. I don't want to dwell too much on this. But the reason I thought it's good to show this is just to see where, some of the cardiometabolic health prevention, cardiometabolic disease prevention interventions, where some of them fall, and where that tailoring really happens. I do want to say that I had intended to present a specific project, but I ended up putting some highlights. So I'm going to highlight some projects that have done this tailoring that we talked about, and some projects that have really used implementation science approach. The other ones I wanted to highlight is food is medicine initiatives, use of digital health tools, team-based care, individual tailoring of support, and medication adherence strategies. All of these are general strategies that we're probably familiar with, and some of them in some projects have been done really well in terms of making sure that they meet the needs of the people who need them the most. So team-based care is one of those approaches, which is, some people know this as task shifting or task sharing, but the idea here is that the healthcare team can be expanded. There are some things that members of the healthcare team can take on, and services that they can provide to patients that would ensure improved outcomes. And some examples of this, sort of looking at this through a global and local context, is, for instance, the Rich Life Project, which, as we all know, was co-led by Dr. Cooper and had that care coordination and community health worker linkage, and was implemented here in the US. But then there is a similar study called the Hypertension Treatment in Nigeria study, which has elements, some of the components of, for instance, what the Rich Life study implemented. And this HTN is being implemented in Nigeria. So sort of really looking at how a lot of these studies have very similar components. And the intervention here is to deliver team-based care as a whole, as a package. There's the Adinkra study, which Dr. Kumademensa has led in Ghana. But I thought it's good to highlight these different studies just very briefly in terms of how these interventions can work across different settings. And in terms of the outcomes, these projects have shown really great outcomes in terms of improving blood pressure, increasing access to care, improving treatment for cardiometabolic conditions and control. Another example is when we leverage digital tools. One thing I've learned recently is that when we talk about digital tools, of course, sometimes people want to talk about digital health inequities, and that is very important. We should talk about that. Sometimes that also presents opportunities for different ways to use digital tools. And I'll give an example. Some of the work that I've been involved with in other countries outside of the US, where internet and Wi-Fi may not be readily available, has been leveraging cell towers to collect data and to still communicate with participants. So there are innovations that do come out of specific situations that we can actually learn from. Again, going back to the concept of reciprocal innovation. Now, here's an example of leveraging digital interventions to improve cardiometabolic health. And here are some studies, for instance, the hypertension management using remote patient monitoring study, Link BP study being conducted here. There's the Low Salt for Life study that used the mobile app, adaptive mobile app, really, to monitor participants. So here are some other examples. And finally, I wanted to highlight community-based interventions because this is really important, but also highlight the differences in settings and how interventions that may have worked in faith-based organizations can also be adapted to work in places like barbershops. And here are also some examples here, which people on this call have led. But here are some interventions that have been tailored to those different settings and that have really yielded some really good outcomes. And finally, the Food is Medicine initiative, which has really taken off. And these are some interventions as well that has worked in some places in terms of produce prescription, delivering produce, that is also being adapted in several places across the world. I do want to say as well as as I close this, is one thing I do want to say is that there are some a good thing that is happening right now is creating networks of tailored interventions such as this. And there is benefits to having network of interventions so that interventions and projects are not siloed. And I wanted to highlight the Match Center here at the Center for Health Equity and the different projects and what these projects are doing. And there is that element of ensuring that each component of these interventions are tailored to the different specific populations. And another project that we may have heard of is the Restore Network, which is addressing social determinants of health to prevent hypertension. And this project also has that element of being implemented different settings among different populations with a very similar goal of improving cardiometabolic health and ensuring that people have people who may be experiencing social disadvantage have their social needs met. Okay, so as I sort of close this out, and I'm hoping for sort of another opportunity to really dive into some of, especially the global projects. I didn't have an opportunity to do that as I prepared the slide. But I do finally want to highlight some essential elements for successful collaborations, and both locally as we work with our local partners, but also across the world, ensuring, for instance, that priorities are as aligned as we can have them be, having joint priorities, shared value, shared visions, and shared goals towards implementation of some of these strategies. Engaging multi-sectorial stakeholders, ensuring there is representation in terms of the people who are actually planning the intervention, active participation in planning and working on this on the project, ensuring that the people who are really the decision maker are the people who would benefit most from the project. So in terms of working with community, in terms of stakeholder engagement, in terms of relationship building, ensuring that people's voices remain centered, and with the goal of ensuring that we have a purpose, a goal, which is to continue to advance health equity, and to do this by really bringing in the voices of the community and the people who are most impacted by cardiometabolic conditions. Thank you very much. So this is all I've got.
Thank you, Bunmi.
Thank you, Bunmi.
Mhm.
So,
I guess before we open up for questions, or if you have questions, you can put your raise your hand. Thank you for that very sort of broad and perceptive overview of the issues of cardiometabolic and kidney health inequities within and between countries and geographic regions. So it was really like chock full of insightful and up-to-date, data and information. So thank you so much. Could you tell us just a little bit about where you see yourself, your own work going within this broad context? What is a particular project that you are hoping to work on as you begin your professional career as a a junior faculty member?
Sure, absolutely. Well, one project that I'll probably be working on very soon is a food is medicine project, which is called Thrive. And it's a project that we have sort of developed with the idea that we don't only want to focus on what we think is important. We also want to focus on the things that people have said is important to them. And so it has that food component in the sense that we have produce prescription included. There is dietitian coaching, so ensuring that people have opportunities to meet with dietitians to talk about their diet. But very importantly, we have created a system to link people to social resources. So people who may be experiencing other kinds of social needs that are not met, we have implemented a system to digitally assess for those social needs and also link them to resources that are around them. And I think one thing that's really nice about that is we're linking them to resources in the zip code that they live in. So resources that are around them that they may not even be aware of. But yeah, that is one which will be starting very soon.
Awesome. And who will be the people who will deliver the intervention? Who are the interventionists in this?
So for the dietitians, we're making sure that the dietitians share similar cultural backgrounds to the participants. For this project, we'll mainly be recruiting Black participants. And so we're making sure that the dietitian who will be working with them share a similar cultural background. So that's one. And then we also have community health workers incorporated into this model, and they will also be working with them.
So dietitians and community health workers working together with, are these people living in communities? Do they have to have a specific medical condition or anything like that?
Yes, so these are people who have hypertension and who live in high priority food areas or places we used to call food deserts or food insecure areas. But we now call high food priority areas.
Okay. Awesome. And who's the funder of your works?
It is the American Heart Association.
Okay, awesome. That is wonderful. We look forward to hearing. We'll invite you back so we can hear more about the project once it gets going. Does anyone else on the call have questions for Dr. Ogungbe? People are quiet today. Yes, let's see. Were there any challenges that you faced when working with community stakeholders in your research?
Oh yes, absolutely. And this is sort of where I'm now wishing that I'd really highlighted some key projects. Next time I will. But yes, there are some challenges that some of which I think are I even hesitate to call them challenges because they are more challenges from the research perspective or from like a researcher perspective, but they are reasonable. Sometimes they are reasonable things that community partners or community stakeholders have raised. So an example is just in terms of logistics and how we conduct research. There was a particular study called the AfroDPP study. One of the studies are highlighted. And we conducted this within faith-based organizations. And we really were working with African immigrants. And I could tell you how a lot of the just knowing exactly when people will be in the church, knowing exactly when we want to go in and actually deliver intervention, having people have the time, for instance, to attend some of the lifestyle sessions that we were delivering as part of the intervention. So here are some I think the broad answer to your question is the sometimes priorities do not align. Sometimes people have busy lives and people have different things that they're doing, and having them be part of the research may take a lot of convincing, and that has been one of the challenges that we faced. Other challenges include the digital literacy and ensuring, especially when a digital intervention is being delivered, and ensuring that people actually understand how to use the devices or the apps or anything that we give to them. These are some of the challenges. Other things are, I do want to say, sometimes people may not quite understand how research works and how some things take a lot of time and how some things we want to do quickly. So again, going back to that, sometimes priorities may not really align.
Mhm.
And that can be a big challenge.
Yeah, we've experienced similar things in our work, and some of the barriers are maybe our own barriers, right? Because we make things unnecessarily complex, or we haven't really taken into account the fact that of what people's priorities are. So it's not them, it's not their barrier, it's our barrier. It's our barrier in many ways. But there are also creative ways to address those issues, as you mentioned. Sometimes early in the research, you do a lot of, if you have stakeholder engagement from early on, you can sort of anticipate some of the issues that might come up, and then try to prevent them, or at least try to be flexible in your ways of delivering the intervention, or your times at which you make programs available and things like that. So Dr. Cruz is leaving a comment in the chat saying, thank you for such a comprehensive talk. Since you finished your training, I wonder if you could share what you feel is important for preparing the next group of researchers who will work in cardiometabolic health equity. Yeah, so just think of it, what would you need, and what do you think your peers who are in this field, what's important in terms of what they would need to think about or need to have access to, or whatever?
Yes, absolutely. I would say two things. There are a lot more things that are important, but the two things immediately coming to mind. One, I would say, is very strong mentorship. I think I have really benefited from that, and I cannot stress that enough. It's important to know who to collaborate with, how to even go about that, and mentors and sponsors really help facilitate that process. So that's one. And then secondly, I would really think about knowing what is important in terms of the work that one wants to do. Really going into the work with a purpose, if that makes sense, and doing a lot of introspection to ensure that one is doing that work because one has that predetermined purpose, because it can be very challenging, especially this community-based work, community-informed work can be very challenging, can be tedious, takes a lot of time. And I think it's helpful to have that purpose in mind and to continue to be led by that. Because some things can be discouraging. Some days will be very hard and one may want to throw in the towel. So those are the things. I don't know if that really answers your question, but those are the two things. I think it's important to have a purpose outside of it just being a job or just being regular research.
Absolutely. I think I understand what you're saying. And I even say the same thing to people 20, 30 years later, when I look back on my career, is really having the long view of this. We know that these problems are really long-standing, and to come into the work thinking you have a quick fix for something, or that you have it all figured out, or that the answer is really going to get you into trouble. So is being humble as one of the things I share, and then also, as you suggested, finding a focus, because I think there's so many aspects of these problems that we can get lost in the complexity of it. So while it's important to acknowledge the complexity of it, it's important to find a particular thing or a particular group of connected factors that you feel like you can contribute to and fill a gap on, right? And that's the part that involves like a lot of the soul searching that you mentioned. So I hope the other young investigators on the call have, you know, benefited from hearing some of these perspectives. Anything else anybody want to ask or share with our speaker or with each other? Okay, I know it's sort of late in the day. Thank you so much, Bunmi, for getting us started in 2024 with a very instructive presentation. And I love your graphics, by the way. We should talk because your slides are beautiful. But I also want to say, in addition to Happy New Year to everyone, please join us again next month. Next month is Black History Month. Next month is American Heart Month. And we have a fabulous speaker, Dr. Michelle Albert, who is a cardiologist and health disparities researcher at the University of California, San Francisco, and also former president of the American Heart Association, who is going to be our guest speaker. So you won't want to miss the Health Equity Jam session in February. So stay tuned and we'll be in touch with you. And thank you for joining us today. Thank you again, Dr. Ogungbe.
Thank you.